Thank you both for finding the time to talk with me about patient navigation.
ACS actually has quite a history with patient navigation. And in this particular instance, it's getting the breakthrough that's already been discovered through research to people. There have been such rich research programs that have been done by University of Alabama, by the whole state of Delaware. Love to talk about both of those examples, but showed the importance of patient navigation. And ACS previous history actually funded patient navigators in a very different way than we do right now. But when I came to the American Cancer Society, when Dr. Kamal came to the American Cancer Society, we agreed early on getting patients access to patient navigation was one of our main goals. And that actually rose beyond patient support all the way to the top level of the organization. Our entire executive team, when we looked at what are the programs that we could run that would really accelerate our ability to improve the lives of cancer patients and families and get us toward our vision of ending cancer as we know it for everyone, understanding that for everyone is really what ACS is about. Patient navigation, without question, objectively rose to the top of what it is that we wanted to give people access to. So we've been very passionate about it. I know Arif is too.
Yeah, and we really saw the challenge as about capacity building, and we've done that in various different ways. As Dr. Knudsen mentioned, one, we've funded navigators within health systems, and those are not long-term strategies. They're certainly sort of short-term ways to help us learn, build the evidence base. But really, we've met an inflection point now where the evidence base is very clear in various audiences and various contexts, both standard of care and clinical trials, as well as various diseases, that navigation works and it improves outcomes at the patient level, caregiver level, health system level, and total cost of care, which is really something we all care about. And so it was important for us, as we saw this opportunity to continue to build capacity, that we sort of rose our hand and said, we're going to help do this through sort of the national infrastructure that we have. And as a trusted partner, we have been in this space for over 30 years. So it made natural sense for us to come in and start thinking about how to standardize the delivery of care and make sure that the bar is high, because patients deserve a high quality of navigation care.
Mm-hmm.
If I can just pause, sorry, I don't want to interrupt too much, but I just do want to make a distinction about something at the outset, and listening to Dr. Kamal, that I want to make sure anybody watching this really is clear on, and that this ruling for CMS provides access to lay navigators. And that is a great first step. And we know lay navigators can make all the difference from cancer prevention all the way through cancer care. Key. But there's an and that needs to happen, and that's clinical navigators. And that's what we have been funding as ACS. Even before I came to ACS, ACS had a history of funding patient navigators. We had one at Jefferson Health previously. But the challenge there is they were employed by ACS. So they were unable to, for example, access the electronic health record. When I came to ACS and Dr. Kamal came to ACS, and we put together these patient navigator grants, which are being funded to it's 20 different health systems, right?
That's right. Yep.
Across the country, those are clinical navigators, and so we're still learning on the so the learning collaborative continues that Dr. Kamal was talking about. So we still have work to do on patient navigation. This first win is for lay navigation, and we've got a lot of experience with that as well. But the North Star, clinical navigation.
Mm-hmm, mm-hmm. Well, when Harold Freeman came up with this idea, or rather when the idea found Harold Freeman, this was about disparities, even though that wasn't the word used. Now, what about reimbursement and standardization? That seems to be where you're going now with clinical navigation. Yes?
Well, but I think disparities can also, there's strong evidence, right, that disparities can be eradicated even through lay navigation. So the whole state of Delaware leaned in with money from tobacco settlement, as I understand it, understanding that Delaware previously had some of the worst, if not the worst, cancer death rates in the country. And so, circa, I think 2018, they leaned in and provided lay navigation, individuals out in communities who were trained to help people get through cancer screening and cancer care. And they were able to not only reduce cancer death rates within the state, but significantly close the gap on cancer disparities. So that's what we mean by some of these experiments already being done. And, Dr. Kamal knows better than anybody, because he runs, ACS runs the National Navigation Roundtable that looks at all of these best practices and looks at all the evidence. But, certainly both lay and clinical navigators, I think there's strong support for reducing cancer disparities, which is one of the reasons we're so high on it.
Very much so. And, you can think about navigation in a continuum. And so, on one end is information navigation. So for people who have a question and need it answered, they can call our contact center, 1-800-227-2345. We get 250,000 calls per year. Those are people at 2 p.m., 2 a.m. who have a question and need to be navigated to the answer. That's very clear. We've been doing that for a long time. Other types of navigation include, peer navigation, where someone finds a person like them in an unpaid setting, right? And we've created an app now called ACS Cares. And the idea there is to find people who have something in common to navigate each other. Let's say a person who's been through a prostate cancer experience can say to a person newly diagnosed with prostate cancer, okay, well, let me tell you how to manage your journey. But that's a very, kind of lay type of approach. The new CMS changes now allow for reimbursement for what is professional non-clinical navigation. That's going to be people who work for health systems, work for county health departments, are employed, but whose background is not clinical. So they're not a nurse, they're not a social worker. This is sometimes called community health workers. It's very vernacular, used across the country. That workforce had oftentimes been funded by philanthropy. And so to your question of disparities is, yes, to Harold Freeman's point, you would want lots of professional non-clinical navigators in place in Harlem, as an example. But often what we find is that health systems who can afford to hire this workforce without having a Medicare reimbursement were oftentimes the ones who weren't necessarily geographically in the places with the largest disparities, right? That the disparities are also financial in nature sometimes. And so the ebbs and flows of money that would fund that workforce was one of the reasons that programs like this couldn't take off. So now that CMS has allowed for reimbursement in this space, what we see is an enormous opportunity to close disparity gaps, because now you can find people with similar lived experiences who come from the communities of the patients they serve, who now can get paid to do this work in a consistent, standardized way. So not necessarily relying on philanthropy, but really having a continuous mechanism of reimbursement through Medicare.
When you mention CMS, what does it do that hasn't been done before?
Yeah, well, maybe I can start and pass over, but having had a lived experience, right, of running oncology for a 16 hospital system across 2 states, and including the only safety net hospital in Center City, Philadelphia, patient navigators make all the difference. And to Dr. Kamal's point earlier, patients who are navigated understand their care and they're able to complete their care as planned. So they also have, so they have better outcomes and also lower cost of care. They don't end up in your emergency department, and their overall cost of care is lower. That the whole University of Alabama experiment showed this as well. The overall net ROI, even economic, for patient navigation was just incredibly strong. But it's so hard to find those dollars to pay for a patient navigator. Philanthropy is one mechanism. Those of us that were on the oncology care model also delved in, because understanding value-based care is coming, we did this at some of our sites, delved into those dollars to pay for navigation. But you were always concerned about durability of funding because there was no way to reimburse for it. And so the CMS ruling is incredible in that now there will be a durable mechanism for lay navigators or certified navigators in concert with a clinical team to be reimbursed. So it will create a durable workforce.
Yeah, so this is the first time ever that CMS has recognized this workforce in a reimbursement mechanism, right? Because CMS, the proposed rule, identifies who can bill Medicare for services, and historically, community health workers or professional non-clinical navigators have not been identified as a workforce that could do that. And so, as Dr. Knudsen mentions, what people had done was a bit of creativity, right? So you could have clinical navigators bill chronic care management codes and other things. So people were kind of trying to piece together the right way to do this to make sustainability. Now we're sort of outside of that creativity zone to a place where it's mainstream now to be able to, as of January 1, deliver navigation services, both sort of incident to, as it's currently written in the rule, and then going beyond. So what that means is that the patient still has to be under the care of a physician. That physician has to see that patient at least once, and then sort of associated with that clinical visit will be navigation services that can be delivered either in person or through telehealth. And that can happen a couple times per month over the next sort of subsequent months. And some of those rules are still being sort of finalized in terms of how we interpret them. But what that means is that navigation is not dependent upon the primary clinical team delivering the services, so the physician doesn't have to be involved in every delivery of the services, and that the navigation team can tailor sort of the dose of the navigation services to the patient that they're taking care of. What's also clear in the rule is that the rule is applied from the point that a person has sort of a suspected finding. So though it doesn't include cancer screening per se, the moment that sort of an abnormality is detected, this rule can be applied, meaning that navigation services for complex care, and that can go through the course of treatment, then even through survivorship, end-of-life care, palliative care, wherever the patient goes. So it's really a longitudinal model where you can create relationships, right? And you can create sort of a trusted series of events that are going to happen. For example, well, we'll check in with the patient once every 2 weeks, and then every month, and then maybe a quarter while they're into survivorship. So that's the real big difference that's coming from this rule.
Consider the woman who goes into her mammogram and has an atypical finding. Now she's not a cancer patient, right? But she now has a very different life than she had before. Maybe she's on tamoxifen for chemo prevention, right? She also needs a very different screening cadence than someone who is of average risk, because now she's in a very high risk zone. So, this is why this ruling is so important. It starts for people who are in this early phase of a precancer or cancer identification to help make sure that they don't fall through the cracks there. Because it's so important, as I know you know, Paul, to have cancers detected early if we want to maximize outcomes for people. So it is, so critical that the timing, and the language allows for that early engagement of a patient navigator.
Mm-hmm. When does the proposed rule become a final rule? And how does money begin to flow?
January 1. This is one of the biggest celebrations I think we'll possibly have in my time at the American Cancer Society. I mean, this really is a major step forward toward improving outcomes from cancer. If what's been seen in the instances where navigation has been employed in health systems that can afford it or use philanthropy, and the studies have been done, if that replicates in the places where navigators then come onto board, this is a huge win for people.
Mm-hmm. Mm-hmm. You must have advocated for this, yeah?
Oh yeah. So, early on it's actually, I'm gonna say it was even the first day I remember interviewing Dr. Kamal to come to be the first ever chief patient officer of the American Cancer Society. And one of the things that we both kind of agreed on right out of the gate is patient navigation is one of the most important things that we can do outside research, but to get that done, we needed to advocate. And so Lisa Lacasse, President Lacasse, who heads our ACS CAN advocacy arm, which is a 501c4, right? That means we can take very bold steps to advocate on behalf of cancer patients and families. We got to work in terms of publishing opinions, but I was invited to the White House multiple times during the planning of the reignition of the Moonshot. And each time I walked through the door, I had patient navigation at the top of my agenda of this is something that we can and should do. And then I actually had the good fortune to write an opinion piece with Dave Fredrickson, and it was, we called it ground shots. Here are 4 things we think the Biden administration can do to significantly accelerate ending cancer as we know it, and patient navigation was one of them. And Dr. Kamal, in parallel of all of these efforts, has been working tirelessly in his own team to fund patient navigation, but also running the navigation roundtable. I mean, that's a really powerful organization that's told us what navigation can and should be, but also emphasize the importance, right, Arif, of what navigation can do for people.
Yeah, absolutely. And what we recognize through that work with the National Navigation Roundtable, which you mentioned, Dr. Freeman has been a both chair and member, and now honorary chair for our organization. What we recognized is that, one, we first needed sort of a sustainable reimbursement pathway. That'll lead to capacity in the United States because it was so sort of varied because of the reasons we talked about. But then shortly after that would need to be follow-on work to make sure there's standardization of good practice. Because as it turns out, it was a bit of variability in terms of how it was delivered, how people are trained. And what we found from our own work is that the majority of people doing this work today receive very little training, very little oversight, and much of that training is sort of done in-house. And so the ability to compare and contrast best practices outside of one's own institution was quite limited, right? Because you can imagine there's kind of sporadic activity happening throughout the country. Now, what this is really about is building capacity, because what we want to make sure is that, it's one, great, the rule is in place, there's a reimbursement pathway. But, just because that exists doesn't mean that everyone's going to sort of, show up tomorrow and start doing this work. And yet patient need is very high. So what we did at the American Cancer Study is raised our hand from the very beginning. I mean, this rule really came out in August or so, was not finalized till November. During that period of time, we said, well, look, we're a trusted member of the ecosystem. We have relationships with all the health systems in the country. That's how we do our work, is through that collaboration. Why not build an easy button for how to make this work? And that involves both sort of standardization, ongoing continuous education, and sharing of best practices through a partnership where we can be sort of the neutral third party, right? We can be there to bring people together. Our goal, our objective as ACS is to make sure every cancer patient has access to high quality navigation services, period, full stop, right? So how health systems want to do it, where they want to focus, clinical trials, which diseases, so on and so forth, that's up to them to decide. But we want to bring them together. So what we created is something called ACS Lion. It's the Leadership in Oncology Navigation, LION. And we believe that's the right sort of, kind of imagery, actually, to think about sort of bold leadership to move this forward. Because, January 1 is coming up, right? So we want people to stand up really quickly and think about the capacity in their own health systems, and then how to create the right services for them. And so in addition to providing credentialing work, this is what our Lion program does, we're also creating convenings to bring people together, to teach them about the new rule, teach them about how to do an environmental landscape of their community, their patient population, and their existing services, and then create a community so that they can learn from each other. We recognize that there's going to be early adopters, those who sort of say, great, we're ready to go. We'll get credentialed through ACS Lion and we'll move forward. But there will also be a group of health systems who are going to say, well, we want to do this, but we need a little help. We want to learn how others have done it before we sort of jump in, because it's still, a financial investment to take on. And we want to right fit our services to the patients that we serve. So what we're also creating is a learning collaborative in early 24 that will bring together folks to say, let's think about who are in sort of the contemplative stages of this, how to build this so that they can have a runway towards starting their own navigation programs, sort of Q3, Q4 of 24. And so that's sort of part of our overall program of capacity building for navigation across the country. That's both standardization of services, community building, and then, helping people sort of set up their programs and move forward.
Mm-hmm, mm-hmm. What is the patient navigation roundtable?
Maybe it's a time where we can just talk about roundtables writ large, right? So this is something that even before I came to ACS, I knew about roundtables. I didn't realize they were run by the American Cancer Society, and they're actually a major investment for us. And so it precedes both Dr. Kamal and myself, and it has been a strategy to bring minded organizations to the table, to share best practices, to learn, often resulting in like a white paper or a position that's not just an American Cancer Society position, but a joint position on what things should be. And in fact, our most recent roundtable, which was the breast and cervical cancer roundtable, we actually launched at the White House at the invitation of Dr. Biden, because the first one had been 30 years prior. It was the colorectal cancer roundtable, which really significantly advanced knowledge and awareness about colorectal cancer screening across the United States. So all of this lives in the current era of ACS now as one organization underneath Dr. Kamal as the Chief Patient Officer.
Yeah, I mean, it's one of our superpowers. I think that, this idea that we can bring people together who are themselves the experts, but who need, an opportunity to get together and talk and create work groups and really move work forward. I mean, it's one thing to have a conversation. Roundtables are about action. And so you'll see that all of them, everything from, as Dr. Knudsen mentioned, the Colorectal Cancer Roundtable started the first 80 by 20 campaign. That was 80% of adults who are eligible for colorectal cancer screening, received screening by the year 2020. And that campaign came out from the roundtable, but not only that, all the tactics, the toolkits, the individual reach outs to health systems, the QI projects, all that emanated from these groups. So the National Navigation Roundtable has been around for a couple decades. The idea is to bring together everything from payers to pharma to health systems, anyone who's touching this problem, this very big elephant in their own way, into the room together to talk about it. And what was clear is that the roundtable got together and created one of the first set of standards called the PONT standards, the Oncology Navigation Standards. What we also recognize through the roundtable work is that for navigation to truly grow, it needs fidelity. And fidelity comes from making sure that the right best practices that have been shown in those studies are the ones that people are implementing. Because what we need to be at is implementation science, not sort of the formative research. The formative research has been done, is very strong, is very compelling. But just like everything else, it's about how is it actually implemented in particular communities. And that's what was brought up through the roundtable as the next big challenge, is how do we make sure there's fidelity in the implementation? So in the creation of the ACS Lion program, it's really around creating credentialing so that every, professional navigator in this country has a basic set of knowledge and expertise and a community by which they can run things by, so that we're kind of doing this all in a way where we can trust what's being delivered, where patients can understand that they can trust what's coming their way, and that we're also paying attention to the quickly changing regulatory landscape, the quickly changing clinical trials landscape. So in fact, for us, credentialing is not an event, it's a process. And so what that means is that we initially credential them, but then every year, make sure we have regular touch points with this credentialed workforce to make sure they understand as the CMS rule changes, which it might evolve, that they've got first in line to that information. As the evidence base changes, they've got first in line to that information. And because as we at American Cancer Society have inroads into the White House Moonshot, into various other organizations, we can bring to them as soon as there's late breaking news what those evolutions in clinical practice should be. Because fundamentally, navigation is rapidly changing as well in terms of how we do it and so on. Mm-hmm. And you might have seen Dr. Bertinoli, really talk about now, right, who previously on our board and then NCI director, now NIH director, a big focus on bringing people into clinical trials. And so you could imagine a big emphasis in this navigation workforce on bringing people into clinical trials, but there's going to have to be some new and different methods maybe, or new and different thinking, and we're here to help distribute that to this credentialed workforce as well.
And if I can just layer on just a tiny bit to that, I totally agree with everything Dr. Kamal said. One of the things that's so important about the Lion program is the standardization, because when we previously, we talked to a lot of different stakeholders. One of those stakeholders are payers. And we talk to payers or large primary care networks, they worry a lot about mission creep, because in their experience, to Dr. Kamal's previous point, when they brought on navigators, bring them in for one skill set and it starts to drift. Mm-hmm. The credentialing allows a very clear vision of this is what a navigator does and doesn't do. And so, but it's also the case that we're going to need to continue to understand what are the needs and add to those skill sets. So in addition to the roundtable, Dr. Kamal worked very closely with AACI to listen to the 106 larger cancer centers in the United States, which come in very different flavors, right? Urban, rural, and say, okay, like what are you guys needing in navigation? And they served as a great sounding board, I would say, for how it is that the Lion program was structured. And that's just an example of Dr. Kamal reaching out to other organizations, even beyond the roundtable. So we feel really, really good about this first iteration, because it's been shared with so many and the idea is shaped by so many.
Mm-hmm. are the principal illnesses as defined by CMS? How does this rule address high-risk conditions, like cancer?
Yeah, so principal illness navigation is the term that the rule talked about, and they're really allowing health systems to define patient populations who are at high risk for poor outcomes, particularly because of trajectory and how they move through the system. So you can imagine that's also going to include other organ dysfunctions. But we know that a large part of this rule is really focused on cancer because cancer is increasingly becoming, as we know, for many illnesses with a chronic illness type flavor to it, right? So it starts to look a little bit more like neuroendocrine tumors start to look a little bit more like heart failure than they were 10 years ago or 5 years ago. And so that those challenges can compound on each other, can be longitudinal, can be interactional with other things that are happening. And what we recognize is that a core component of navigation will be assessment of social determinants of health, because we recognize is that social determinants of health, right, are really just a function of circumstance and time. So we can have all the sort of resources at our fingertips right now as individuals, but if I give you a cancer diagnosis that goes on for 6 months and then 16 months and then 6 years, right, it's hard to imagine that at 6 years any one of us doesn't have some sort of logistical, financial, social, emotional, relational barrier that we're going to come up against. And that's really what this navigation is about, is to get people to and through the right care, but also to be a trusted partner as they're going through the system and as they're going through their care, because that can oftentimes, now as we see, particularly in cancer, just like in heart failure or liver disease, last for several months or years at a time. And that recognition that there's similarities there really makes it so that navigation is not an event, right? But in and of itself is a longitudinal process.
Yeah.
Is there?
And I think the other thing about this ruling to note, though, and we talked about just really briefly, but I think deserves some emphasis, is that it includes telemedicine or telehealth, for navigating. It's like, what a great win there too, right? So that people aren't having necessarily to travel into the health system to get access to the patient navigator. That's so important.
Yeah. There are companies, a few of them, very few, that are trying to do this as well. How does the really private sector fit into this? How different? Is there another model to work through? Does that?
Well, in the challenges, there are a lot of functions that people sweep into calling navigation. That's again why it's so important that we have the credentialing process, because some of these things that people are calling navigation wouldn't necessarily meet the criteria of what oncology navigation from the strict sense looks like and what we're certifying people to do. Does that sound fair, Dr. Kamal?
It does. And we are, we're here to make sure that the quality is high. The tax status of an individual organization is not really of our concern. I will say this, we had a very robust pilot our ACS line program, sort of as a soft launch here in November. And we included vendors as well, who will likely participate in this space after January 1. And so, we wanted to see their experiences, and across the board in our pilot, high satisfaction by users of the credentialing program, both from academic health systems, community-based organizations, but also the vendor space as well. I think what Dr. Knudsen and I and the American Cancer Society are very interested in addition to the roundtable, is making sure that we don't create, that we keep the bar high, so that there's not a race to the bottom. Obviously that's always been a concern. When CMS comes out with a new program and there's a set of dollars, right? CMS, the Moonshot, us, everyone, right? We want to make sure that people get the right care. And what's not happening is, what's the least amount of care to be able to be eligible for getting that reimbursement, right? We're all very interested in making sure people don't get the least amount of care. And what the credentialing program really requires is it says, not only here's the skills and expertise, but here's what good high quality navigation looks like, right? This is what it looks like day to day, week to week, month to month. And that's really what needs to happen. And this is why we believe it's so important to have credentialing. Because remember, any other sort of clinical space, imagine that everyone, I'm a physician. So everyone is a physician, right? That they went to school, they went to residency, they went to fellowship to be oncologists, they're credentialed by the state Then they're also, I have a DEA number, I have an NPI number. So CMS has credentialed me, the DEA has, the state has, my health system has, and I have to show all this documentation of all the places I went to school. Same thing with Dr. Knudsen as a cancer researcher, right? The same, and as administrator, same thing has always been the case. Now imagine a workforce where there's a lot of variability, and there's beauty in that in terms of their professional background, how they were educated, and so on. But it also means that we just have to pay attention to sort of the standardization of the workforce and the delivery of what's happening.
So the role of ACS is to establish standards and credentialing system, which is what you're rolling out right now.
Yeah, and luckily those standards had already been, we were able to learn from others that, who'd done research on this in the past. We're able to vet our ideas through the roundtable, through ACI, and really assess, how it would be received. But it'll still be an iterative process where as oncology care delivery changes, we'll constantly need to refresh the credentialing strategy. But luckily it was the meat of it was already there, and we were already helping to train navigators across the country. So lifting it up really just required some formalizing of what it is that we do right now. But it was one of the greatest phone calls I think I've ever made, because when I got in August the tip that this was coming and the CMS rule was going to be proposed, I called Arif immediately, like, oh my gosh, we got a lot of work to do before January. Let's get, and he and his team basically literally abandon things that could be abandoned in order to really prioritize this, to make sure that we weren't missing a day of someone being able to access credentialing strategies and training strategies so that they could be deployed as a patient navigator. We really considered it one of our most critical goals, outside the transportation, lodging, things we do every day at patient support. But as in terms of ACS priority, this is right to the top.
But it would be really up to the participants in the program whether to seek your seal of approval, even though it would be prudent.
Yeah. In fact, the finalized CMS rule states that for navigators to participate in the CMS reimbursement program, now, private insurers can do what they want to do, but to participate in the CMS program, they have to be credentialed. So that is a requirement. And, ours is, as of January 1, stood up and ready to take people into the credentialing program and into the community to, of our learners to learn from each other in terms of how to do that. So that's really clear. What we want to make sure people understand is that this opportunity exists, that there are proven methods of how to do this. There's a community from which you can learn. There are standards of which will help you learn and then get you approved so that you can bill CMS. But that's one of those things that can start in January, right? You come to our program, get credentialed, start billing Medicare and moving forward. That's for those early adopters, and then others will sort of pick up from that. That opportunity starts January 1. I mean, that's what's really clear, is this is not a concept, a philosophy, a thought, an idea. This is actually happening. And to Dr. Knudsen's point, we believe this is going to be the right momentum to build up, a lot of energy and force behind the idea that clinical navigators need to also have the same reimbursement pathways, right?
Next step.
Right. And you can imagine that we will be there to think about how to standardize that practice as well, so that you really do see this as a continuum. Because you can imagine for some patients, clinical navigation, real in-depth clinical navigation is what they're going to need. For others, maybe it's going to be professional non-clinical navigation, like what's been sort of reimbursed for now. Maybe for others, it's information navigation. For others, it's peer-to-peer support like we provide. And that sort of comprehensive menu of navigation options is what we really believe people should have access to. And I think that what you'll then find is we can close gaps like clinical trial enrollment by realizing that for some patients, they really need a clinical navigator to get them into a clinical trial, because it's going to require a little bit more conversation and thought and logistical support to move the blood draw around and the CT around and so on. And for others, it's really information navigation that'll get them into a clinical trial. They just want to know what's the difference between a phase 2 and a phase 3 clinical trial. You answer the question and they're ready to move forward, and everything in between. And so we believe that entire continuum really needs to have reimbursement power behind it.
Yeah, and like one of the things to know in terms of demand, Paul, is because we've studied this so long at ACS, ACS Can had done, surveys because we work with large number of cancer survivors, millions of cancer survivors every year across the country. And 91% of cancer patients and survivors say that they wish they had had a navigator. So the demand is high to get this done. And one of the things that I would be remiss if I didn't point out was how grateful we are to the American Heart Association for Nancy Brown, who's their CEO, and their team being willing to lean in and talk to us about lifting up certification, because of course there's a long history at the American Heart Association of providing CPR training, right? Something that people don't often think about, like, where is that coming from? Mm-hmm. And it's very appropriate that it comes from a neutral third party, evidence-based, with only one goal in mind: help people. No financial interest, right, in where anybody gets care, cardiology care, in the same way we don't have an interest on where anybody gets oncology care. We just want them to get access to the best possible quality care that's going to give them an opportunity for a positive outcome.
Mm-hmm. But that's why you need ACS is to establish this. But when they say you must be credentialed, does it mean, does it say ACS or?
Yeah, so you don't have to be credentialed through the American Cancer Society, but certainly, we consider ourselves to be very, it is an important role for us to take up that responsibility and provide credentialing services that are well studied, that are easy to access, and that will provide standardization across the country. We feel really passionately about the fact that that's one of our major roles.
But if I were to get certified, where else would I credentialed? Where else would I get credentialed other than ACS? Is there another place to go? Is there?
To our knowledge, there's no other program that is aligned to both the PONT standards, which are sort of the well-accepted standards, and to the CMS rule. So the CMS rule actually requires certain things you have to credential around and talk about. For example, things like billing and coding and ethics and compliance, right? Because you're now talking about a billable thing, not just sort of the clinical practice of delivery. So we're, to our knowledge, the only one who's aligned to both of those. We would expect that vendor groups would come to us too, right? So it's really anyone who wants to build Medicare for the delivery of professional non-clinical navigation, regardless of who the employer is, right? Vendor, health system, community organization. It could be a state health department, right? Who is also looking, whoever that is, we see this as sort of the central point for them to come into. And then, like I said, in addition to sort of the knowledge and the standardization and the testing part of it, is also the building of the community. And what we want to make sure is that we learn from this cohort as well. So part of our work in ACS Lion is also to survey these participants, understand what does that look like in delivery, because there will be challenges, right? Reimbursement is but one challenge that's being solved here. The other is really going to be workforce itself, right? We recognize that healthcare right now is already in a tough spot. It's already hard to find nurses and frontline workers for any number of things. You're talking about a workforce that's extraordinarily important, that's providing frontline care, that's going to see a lot of difficult things like other healthcare workforces do as well. And we want to make sure that that workforce is robust, that there's not high turnover, that there's adequacy in that workforce. That's going to be a part of this work. And we're going to learn from each other about what are the best practices to retain and recruit this important workforce.
And get feedback from the health systems too. So we already talked to Rob Wynn, Dr. Wynn, about, who is now the president of AACI and will be for 2 years. 6 months, 12 months in, we'd like to do a pulse survey, and not that they represent every cancer center, they certainly don't, but 106, the power of 106 is a lot of voices to tell us, what worked, what didn't, what do we need to think differently about. So there's learning at the system level, there's learning at the individual navigator level. We see a lot of upside to Dr. Kamal's point, not just launching Lion, but making sure that Lion evolves with evolving needs. We want patient navigation to be a gateway for people to be considered for clinical trial and to have an opportunity for people to talk to them about clinical trial. That's one of the reasons also that we are so emphatic about eventually getting to clinical navigators, because my dream scenario, right, is that there is an opportunity to assess and evaluate someone for clinical trial before they walk in the door. so that, I mean, this is a great best practice that when you can achieve it is done of saying to someone, you know, here's where we are in your treatment plan, or here's where we are with your diagnosis. Here are all the options to you. And one of the things that you may want to consider is, because, you know, unless we do something fundamentally different in the country, we can't just keep doing the same thing and hope that we're going to enhance enrollment of adults in clinical trial. What would cancer outcomes look like if enrollment in clinical trial for adults, understanding that that's the vast majority of people with cancer in this country, match that with what happens in pediatric cancers, where, you know, the reports are a little bit all over the place, but, you know, could be up to 85% of pediatric cancer patients. You're super passionate about this, Paul, as you can tell.
Yeah.
Like this is a huge, we're not going to have wins like this every year.
Yeah, right. I love this. What happens with for-profit, non-CMS stuff?
Well, in terms of what happens outside the scope of CMS, you know, typically as CMS goes, the payers go, and we hope that this follows suit. But I'm back to the demand, right? That 91% of profiled cancer patients wanted a navigator. And so one would think that forward-thinking payers are going to take this up. Now, we do take this as part of our responsibility as well to speak to the payers about the importance of patient navigation. We have before, we will continue to do so. But this gives them a real reason and opportunity to get going. We have had some early discussions with some payers about doing demonstration projects to cover navigation. I'd love it if they'd cover clinical navigation, right?
Mm-hmm.
TBD, more to come.
Yeah, that's right.
So like an Aetna or whatever would be paying for clinical navigation as well. But
wouldn't that be nice? And would give an opportunity to experience for themselves what the impact is on that patient, you know, in terms of outcomes, the most important thing. And also an opportunity to get an experience of how it impacts the overall cost of care.
But if you're pushing people towards, let's say, clinical, towards clinical trials, that would be clinical navigation, or would that be, or what kind of navigation is it?
If you're talking about evaluating someone's eligibility for trial, you know, Dr. Kamal, tell me if you disagree, that's likely a clinical navigator to do the evaluation ahead of time. But if you're talking about educating someone about how to discuss clinical trial, here's what a clinical trial is, here's what you may want to ask, you know, that's something that could get done in the professional non-clinical sense.
And you're doing right now non-clinical navigation. What Lion is not clinical navigation. That's something you're going to go for later.
Well, the Lion is, you know, professional non-clinical navigation, and it is really important, massive win, high impact. But the and is ultimately clinical navigation, and that should happen too. And we were very clear about that with the Biden administration as well. We love this. This is a huge step forward, but the North Star is an addition of oncology clinical navigation.
Okay.
And it may help, Paul. So
Okay.
it depends on how you're using the word clinical. This is so clinical refers to the training and the expertise of the person delivering the care, not the setting in which the care is being delivered. So a professional non-clinical navigator can work in a clinical system, in a clinical environment, but what they're going to talk about are things that they're comfortable talking about. So it may be, what is a clinical trial? What are the difference between a phase 1, 2, 3, 4 trial? You know, who do I talk to if I want to learn more about it? But you can imagine it's going to be a nurse, so that would be a clinical navigator, right? Who could actually then see if they're eligible by looking through their chart, making sure their labs are in line, their physical exam in line. So those are clinical assessments. But the environment that you're in is still a clinical environment, right? They
would work together. They would be, you know, close colleagues here in navigating me as a cancer patient.
That's right.
Okay. But how does one get paid through CMS right now for this starting January 1? How much money can you make, which is a cross question that everybody is asking?
Well, we think that it's enough by our understanding of the RVU assignments to these codes, enough to make it worthwhile to do it. I mean, this is important to do. It's the right thing to do, but it's also a good business opportunity to do it as well. Now, the value not only comes from the revenue, which is what we're talking about here, but also cost avoidance, right? Because as you know, cancer care is driven by two major things. One is drug costs, which is not what we're talking about here. The second part is going to be those sort of low value, and I mean low value to the patient, right? No patient thinks it's going to the emergency room is a high value activity, right? So avoiding ED visits, long-term hospitalizations, particularly near the end of life or when there's complexity, and making sure that those side effects, for example, are handled prior to them becoming out of control, where we have to stop treatment for a period of time, right? Because that happens, for example, in immunotherapy, where we have to stop. So the idea here is that you've got someone, keeping tabs on you throughout this process, who by themselves are not a clinician, but are trained by folks like ourselves at ACS to be watching for particular things, and then to connect into the clinical system when you see something. So a patient calls, or you call a patient as a navigator, and you hear them say, yeah, I'm having a lot more rash and itch. Well, that's important to bring to the attention of the clinical team, because maybe they reduce the dose, stop something, give some steroids, some skin cream, whatever that is, before it gets to a point where the rash is so bad the patient has to come to the ED, be hospitalized, and then be off treatment for a period of weeks to months. So that sort of early warning system, the eyes and ears on the ground, is really what these professional non-clinical navigators are providing. But it's important that they stay connected with the clinical team, and ideally in a future state that's not too far off, a clinical navigation workforce that can come in as the next layer and say, okay, well, let me talk to them about what to do about their rash now that we know that they have them.
And that feeds right into the pathways.
Yeah,
Yes.
it does. It does.
Oh, I got it.
Exactly. And
Okay.
and to Arif's point about the emergency department, this is the least efficient place to get cancer care. It is not where you want your cancer patients landing. And it's also very expensive. It's expensive and inefficient. Nobody wants it. And one of the outcomes that has been very clear downstream of patient navigation is that it does prevent people from landing in this high cost, low efficiency setting for cancer care.
So, but how do you get somebody like, I don't know, US Oncology to play?
I think a lot of forward-thinking community practices already do it. So, US Oncology, so let's just talk about that, right? They have the joint venture with Sarah Cannon because they know they need more access to trials, right? And guess who already provides navigators in the HCA system for all of their sites? Sarah Cannon and HCA, because they know like it's the right thing to do for patients. There's no question.
Right.
But it's also the right thing to do from a business perspective. Take away that it's the right thing for the patient and it still is a good business decision. But it's the case because you have better outcomes, because there's overall lower cost of care. But it's the case that if there was no mechanism to reimburse for it, it was hard sometimes to piece together for some health systems. But I'm just back to it's the right thing to do for your patients. And I think most organizations are driven that way. At least the oncology teams are.
Yeah.
Yeah. How fascinating.
And patients want it, right? Back to the demand issue. It's clear patients want it.
And they definitely want to have your seal of approval. Thank you.